Hypersensitivity pneumonitis, or farmer's lung, is a delayed hypersensitivity reaction to some environmental exposure, such as aerosolized mold or droppings, leading to an IgG antibody type 3 hypersensitivity and a CD8 lymphocyte type 4 hypersensitivity response in the alveoli. Now, this is not a type 1 reaction like an allergic asthma. And also, unlike asthma, this path picture shows that inflammation is more centered in the alveoli as opposed to the bronchi. Symptoms usually show up 4 to 6 hours after exposure, and you can get shortness of breath, a dry cough, chest tightness, headache, and fever. You may also see bibasilar dry rales and decreased diffusion capacity, or the DLCO. If you see the chest x-ray, it may look a bit like atypical pneumonia or interstitial lung disease. Now, in farmer's lung, what's the exposure? It's usually secondary to thermophilic actinomyces bacteria and occasionally aspergillus fungi in moldy hay and compost. And what about bird exposure? Well, this is called bird breeder's or bird fancier's lung. This is due to exposure to avian proteins in the dried, aerosolized bird droppings. Keep in mind this is not psittacosis, where you have a true bacterial pneumonia. There are many other occupation exposure conditions related to hypersensitivity pneumonitis, like malt worker's lung and cheese worker's lung, but farmer's lung and bird breeder's lung are the most common and most likely to appear on your exam. You can treat these patients with steroids, but the main treatment strategy is antigen avoidance. Flash quiz. What type of hypersensitivity is behind hypersensitivity pneumonitis? Answer: type 3 and type 4. The pneumoconioses are high yield and are likely to show up on your board exams, so watch out for this. These pathologic states involve alterations in the normal lung parenchyma as a result of exposure in response to foreign substances such as coal, silica, and asbestos. Now, asbestosis is perhaps the best known pneumoconiosis, especially because of all those late night commercials saying, "Attention, if you or a loved one has been diagnosed with mesothelioma, you may be entitled to financial compensation." Now, of course, the lawyers left out bronchogenic carcinoma, which is actually a much more likely result of asbestos exposure than mesothelioma, especially in smokers. Now, this is due to the fact that asbestos and tobacco smoke are synergistic in their terms of their carcinogen effect. Now, do you recall how we define a carcinogen? Well, a carcinogen is any agent, whether it be a chemical, a virus, or radiation, which damages DNA and increases the risk for cancer. You can read a bit more about the important carcinogens in the neoplasia section of the pathology chapter. Now, some studies have shown that asbestos exposure itself can increase the risk of lung carcinoma 6-fold in any exposed patient, regardless of their smoking status. But the association asbestos has with mesothelioma is much more commonly tested on the board, so let's spend some time with this. So what is asbestos? Well, it's a silicate mineral that was used for a lot of things, including insulation, fireproofing, and soundproofing. Therefore, you typically saw exposure in industries like shipbuilding, roofing, and plumbing. Unfortunately, exposure classically causes calcified pleural plaques, which appear ivory white. In particular, the straight fibers are more carcinogenic than the curved ones. Now, unlike the other pneumoconioses we will discuss, asbestosis typically affects the lower lobes of the lung. As seen here, the asbestos bodies, or the ferruginous bodies, are basically asbestos fibers that develop a ferritin protein coat with a dumbbell or beaded appearance. Anthracosis and coal miners' pneumoconiosis, or black lung disease, is obviously associated with exposure to coal and its byproducts. The inflammation and fibrosis typically affects the upper lobes. As with all pneumoconioses, you can expect certain complications, such as right heart failure and something called Kaplan syndrome. So what is Kaplan syndrome? Well, it's a mix of rheumatoid arthritis and pneumoconiosis in people with intrapulmonary nodules seen on chest x-ray in a homogeneous pattern. Silicosis is also known as Potter's rot or grinder's disease. This is a picture of a patient with silicosis and tuberculosis. Now, what is the exposure to look for on the boards? Well, it's associated with exposure to the byproducts of mining, such as foundries and sandblasting. In this disease process, the presence of silica causes the production of hydrogen peroxide and other oxygen radicals that damage lung tissue. alveolar macrophages take up these particles and release cytokines such as TNF, IL-1, and LTB4. This leads to fibrosis and the characteristic eggshell calcifications in the hilar lymph nodes. Silicosis is also associated with bronchogenic carcinoma and tuberculosis, which is board testable. Here we can see the characteristic eggshell calcifications. Do you recall from the physiology section which cells produce surfactant? Type 2 pneumocytes. And what does surfactant do? Well, it decreases alveolar surface tension, increases lung compliance, and therefore decreases the work of breathing. The importance of surfactant is highlighted in neonatal respiratory distress syndrome, seen in this X-ray, where the pathology is related to the neonate's lack of surfactant. The deficiency in surfactant due to the immaturity of the neonate's lungs leads to an increase in surface tension, decreased compliance, increased work of breathing, and alveolar collapse. On chest X-ray, you can see these diffuse interstitial infiltrates. So who's at risk for neonatal respiratory distress syndrome? Well, classically, it's preterm infants, especially those before 35 weeks. Other risk factors include maternal diabetes and C-section. An important marker of lung maturity is the lecithin to sphingomyelin ratio in the amniotic fluid. Both lecithin and sphingomyelin are lipids in surfactant, but it's mostly lecithin that gives surfactant its properties. Can you recall the most important lecithin molecule we're concerned about here? Dipalmitoyl phosphatidylcholine. In NRDS, the lecithin to sphingomyelin ratio is generally less than 1.5, whereas a ratio of 2 or greater indicates a low risk of neonatal respiratory distress syndrome. Survival is poor in neonates younger than 24 weeks. Interventions to improve survival include administration of maternal steroids before birth, intra-alveolar administration of artificial surfactant after birth, and CPAP or intubation with oxygen. However, too much oxygen in the perinatal period can lead to complications such as retinopathy and bronchopulmonary dysplasia. Now, will an intubated baby develop retinopathy? No. It's more associated with oxygen tents, causing initial cessation of blood vessel formation because the oxygen tension in the retina is appropriate. Once the oxygen is removed, the relative hypoxia in the eye causes blood vessel growth, which can result in blindness. If the baby has persistently low oxygen tension in the blood, what cardiac complication are they at risk for? A patent ductus arteriosus. Flash quiz. Silicosis is associated with blank and blank. Bronchogenic carcinoma and tuberculosis. Acute respiratory distress syndrome, or ARDS, has a number of causes related to illness or acute injury. ARDS typically starts off as a patchy process that involves inflammatory cells like neutrophils and some T cells. Cytokines contributing to lung damage include TNF, leukotrienes, and macrophage inhibitory factor. These substances are toxic to the alveolar wall. The result is an increase in capillary permeability and pulmonary edema. The fluid is protein-rich. In this histopath image, you see inflammation, edema with proteinaceous fluid, and hyaline membranes, which is this glassy, pink-appearing material when you stain with H&E. So here's a bit of board trivia. In which condition were hyaline membranes first observed? Actually, it's neonatal respiratory distress syndrome, which we just discussed. In fact, NRDS is also known as hyaline membrane disease, and in fact, this particular image could pass for NRDS. On chest X-ray, you see diffuse bilateral infiltrates as seen in this intubated 21-year-old patient with a history of aspiration pneumonia. Management of ARDS has gotten better, but it's still a deadly condition. Mortality rates used to be as high as 70%, but have now dropped to the 30s. Patients typically require mechanical ventilation over a long period of time with low tidal volumes and high positive end expiratory pressure. However, during the course of treatment, oxygen radicals from high FiO2 levels can cause what's called diffuse alveolar damage. Sleep apnea is becoming more and more common as the prevalence of obesity increases. An apneic event is defined as the cessation of breathing for at least 10 seconds during sleep. This leads to disrupted sleep and the classic presentation of daytime somnolence. When an apneic event occurs in obstructive sleep apnea, or OSA, which is the most common type, the respiratory efforts continues against airway obstruction. Here you can see the airway is obstructed because of the tongue and soft palate closes the airway. Because you have alveolar hypoventilation and hypoxia, you can get secondary polycythemia from EPO release in the kidneys, and pulmonary artery vasoconstriction in an attempt to shunt the blood with resulting pulmonary hypertension. So does this remind you of anything? Well, it should make you think of COPD, where you see some of the same complications. You can also see right heart strain and the development of associated arrhythmias. So sudden death is a possible clinical presentation for patients with sleep apnea. In addition to daytime sleepiness, you get snoring and the patient's significant other witnessing the sleep apneas. These are the so-called 3 S's in obstructive sleep apnea. When you see obese patients with daytime somnolence, you typically think of OSA. But these patients can also have obesity hypoventilation syndrome separate from or in addition to OSA. This is also known as Pickwickian syndrome. How can you tell the difference? The ABG in a patient with OSA is usually normal. However, if you have obesity hypoventilation syndrome, you'll have daytime hypercapnia with a PaCO2 of greater than 45. Central sleep apnea is less common and involves the absence of respiratory effort due to a failure of stimuli from brainstem command centers. You can see in this chart the lack of inspiratory effort during the apneic event. In other words, this is a neural issue and not a mechanical obstructive issue. Now, what causes central sleep apnea? Well, things to keep in mind include narcotics, heart failure, renal failure, or a recent ascent to high altitudes. Obstructive sleep apnea is typically treated with weight loss, continuous positive airway pressure, or CPAP, or airway revision surgery. With central sleep apnea, you have to treat the underlying pathology, in addition to supportive care with CPAP. Pulmonary hypertension is super high yield, so make sure you star this topic now for later study. Pulmonary hypertension is currently classified into 5 groups, but it's still useful to think of pulmonary hypertension as primary or secondary. Do you recall from cardiology the normal pressure in the pulmonary artery? It's about 10 to 14 millimeters of mercury. Now, when do we get worried? When the pressure is greater than 25 millimeters of mercury at rest. So what is primary pulmonary hypertension? Primary mostly corresponds to idiopathic or hereditary pulmonary arterial hypertension. It most commonly occurs in women ages 20 to 40. One major cause of this disease, although not the only cause, is an inactivation mutation in the gene for bone morphogenetic protein receptor type 2, or BMPR type 2. This is a member of the TGF-beta signaling family whose normal function is to inhibit vascular smooth muscle proliferation. You can think of secondary pulmonary hypertension as being caused by anything else. Take a look at this chest x-ray. This patient is a 38-year-old woman with progressive dyspnea. There's 2 things to notice here: the huge pulmonary artery on the right side of the patient's heart and the enormous left ventricle that causes a large mogul. So what are those conditions that can cause secondary pulmonary hypertension? Well, they include COPD, mitral stenosis, CHF, and recurrent thromboemboli, anything that causes a left-to-right shunt. Some other causes include sleep apnea, living at high altitudes, and certain drugs such as the notorious fen-phen combination for weight loss that are no longer available. Think for a moment about the underlying disease mechanisms and how each might contribute to the development of pulmonary hypertension. For example, what causes a left-to-right shunt and what is the underlying pathophysiology? Well, you typically see this with a congenital heart defect like a VSD, a PDA, or an ASD, which causes more blood to have to flow through the pulmonary circulation to get the same amount of oxygen to the body. This increased blood flow physically injures the endothelium via shear stress, causing them to become thicker, which increases pulmonary arterial pressure. So how do you treat pulmonary hypertension? Well, first you try to take care of any of the underlying secondary causes. Other treatments that you may have learned about include calcium channel blockers, epoprostenol, which is a synthetic prostacyclin, bosentan, an endothelin receptor antagonist you'll hear about more later on, and multiple phosphodiesterase type 5 inhibitors like sildenafil, or better known as Viagra. What are the long-term sequelae of pulmonary hypertension? Over time, you might get cor pulmonale and right ventricular failure. Can you remember from cardiology some signs that might point you towards a diagnosis of right ventricular failure? Jugular venous distension, lower extremity edema, and hepatomegaly. At the end of the day, some patients may ultimately require a lung transplant in order to survive. Flash quiz. What are the long-term sequelae of pulmonary hypertension? Cor pulmonale and right ventricular failure.